I'm Julie Hammond. I'm the Director of Anatomy Trains Australia and New Zealand. I'm a remedial massage therapist and a structural integration practitioner. And I teach the full Anatomy Trains Structural Integration Program, as well as being part of the Anatomy Trains Education Committee. And I'm excited to be teaching at the Massage and Myotherapy Conference here in Perth in June. I'm going to be teaching an introduction to anatomy trains and how it relates to clinical practice. I know a lot of people who have read the book or skimmed through the book and struggle to make it relatable to how they work. So in this introduction, I want to look at the anatomy trains and help you make it relatable to your practice. We're going to look at the myofascial meridians. We're going to look at our style of body reading, so static and functional assessments. We're also going to look at how this body reading can start to inform your strategy and looking at the body from a global perspective. So how a problem in one area could be affecting somewhere completely different. So for example, lack of dorsiflexion in the ankle can restrict hip extension. Also, restriction in the right hip could be affecting left shoulder movement. So we take this global view of posture and anatomy. I first did my anatomy trains workshop, my first anatomy trains workshop with Tom Myers 20 years ago. And I was running a clinical practice in the UK and I was getting results, but they weren't lasting. People were coming back a few weeks later. So I did the anatomy trains workshop and it was quite life-changing for me. It gave me my love of anatomy. It also changed how I work in clinical practice. And it also felt like it was a missing piece of the puzzle for me. In this workshop, my main focus will be looking at the deep front line. So we're going to look at this amazing fascial origami that connects the medial arch all the way up to the jaw. We're going to give you techniques that you can use immediately after the workshop in your clinical practice. I hope that you leave this workshop with the same love of anatomy and anatomy trains as I did when I did my first workshop. So I would love to see you at the Massage and Myotherapy Conference in June.
Hi, welcome to this episode of Massage and Myotherapy Connect. I'm Davey, CEO of Massage and Myotherapy Australia, and I always say I'm super excited when I get to interview people on here, but I think that the two of you are just, it's a topic that I always get asked about, and that's registration, regulation of our professions. So welcome, Bronwyn. I'm here with Bronwyn Morris-Donovan, sorry. And Bronwyn is the CEO of the Allied Health Professions Australia, of which we are affiliate members. And I've also got Antony Nicholas, who is the CEO of Osteopathy Australia. Have I got it right?
Right.
So thank you so much for your time today. As I said, we're here to talk about what AHPRA is, what AHPA is. Two separate entities, but also I just want our viewers to know that this does not mean that we are talking about or that massage has suddenly become AHPRA registered. So what we're trying to do is inform our members of what this all means. So firstly, do you want to tell us a bit about yourself? I'll start with you, Bronwyn. How did you end up the CEO of AHPA? And, it's a big job that I don't envy.
Good question. So my background is in allied health. I was a podiatrist quite some time ago and for a very short period of time. So like many allied health professionals, I went back to university pretty quickly and I did a master's of public health with a major in public policy. So my first job in association land was as a policy officer back in 2003 at the College of GPs. So since that time, I guess I've really worked as a policy professional for the last past 20 years, mostly in associations. So in general practice policy, in nursing policy, a stint at the physios, and now here looking at a more holistic view, looking at all of allied health. But my particular interest really is in primary care policy. Thanks, Anne.
Thanks. And Antony, CEO of Osteopathy Australia, which is a registered profession. How'd you end up there?
Through, like lots of people in association land, through a convoluted path. So I've got a couple of science degrees. I'm not an osteopath or a health practitioner. I've nearly always worked within health, infectious diseases, both in complaint handling, but also consumer representation. And I also was a school teacher for a short period of time. And a friend of mine or a former colleague saw this great ad where they want someone with education and government and a bit of healthcare and et cetera, et cetera. I said, well, what's osteopathy? And well, here I am, CEO of Osteopathy Australia. I'm also the chair of Allied Health Professions Australia. So yeah, great synergy.
Yeah, and I was going to say, I did forget to mention that you are the chair of AHPA, so you work alongside Bronwyn and her team quite closely. Yeah. So, well, yes, and I think you're right. In association world, we all end up here in a bit of a zigzag of a pathway, don't we? So Bronwyn, I suppose to start, what does allied health actually mean? I mean, I know you work closely with the Chief Allied Health Officer, but at a federal level and probably a state level as well. But, what's the meaning behind it, or is there one?
I feel like that's $1 million question. So I guess most of your listeners would probably know that there is no nationally accepted definition of allied health, and that's where our complexity probably starts. So the impact of not having a unified definition is that then the state and territory governments and the federal government include different professionals under that umbrella term of allied health. So at a really macro level, it's not medicine, it's not nursing or midwifery, and it's not dental. And so for some people, it's everything that doesn't fit into that category. But that list is still an exceptionally long list. So there are some general core principles that most people agree sits within allied health. And I'm going to read them out to you because they're quite specific. So the first is that an allied health professional plays a role in direct patient care. It's quite straightforward. But the second is that an allied health profession has a national professional association or an organisation with a code of ethics or a code of conduct and a clearly defined membership criteria. What sits underneath that is that we require that to be an allied health profession, you need to have a bachelor at a minimum, so a health science degree, again, not medicine, not dental, not nursing, at an AQF 7 or higher. So an AQF 7 is a bachelor degree, and that course needs to be accredited by the relevant national accreditation body. So that's a really important distinguishing feature of allied health. The profession needs to have clearly articulated national entry-level competency standards and then assessment procedures, so for how we assess against those minimum competency criteria, a defined scope of practice, a robust and enforceable regulatory mechanism, again, really important, and then that clinicians operate and work within an evidence-based paradigm. So we can come back, if you like, and unpack any elements of those, but even within those generally accepted definitions, we still end up with quite distinguished variation. And earlier we were talking about osteopathy. So osteopathy is a really good example of an AHPRA regulated profession, but it's not recognised universally by all states and territories across the country.
Which is a really big point because, the way our country is set up, politically, it came to light during COVID, obviously, not to keep harping on about COVID, but, every state had different directions, treated every modality, every profession differently, and it was so, I mean, it was so difficult to keep up with it. But
Yeah.
I mean, Antony, did you want to follow on from what Bronwyn said about osteo being a registered profession and the
Yeah.
issues that brings, or challenges? I shouldn't say issues.
Pros and cons.
Yes.
Yeah, so osteopathy in Australia is quite lucky in the fact that we were registered quite early in Victoria and New South Wales 45 years ago. In fact, the first osteopaths registered in the globe outside of the US. So, so we've sort of got a long history of osteopathy in Australia being quite advanced in recognition and regulation. And obviously we're in the first tranche of AHPRA registered professions, so about 15 years ago. And I think quite often professions or individuals misinterpret what AHPRA is about. They think it's a promotion of certain professions and encouraging better standards and whatnot. But in reality, what they are is they're the policemen of the profession. The associations are the promoters and the regulator is the policeman. They set a set of minimum rules that everyone must comply with, otherwise you get in trouble. So they're really, all the AHPRA registered professions are there because they have the potential to hurt people, not because of their high quality or that they're lovely people, they're there because they have the potential to harm people and therefore need to be regulated. And that's a very different perspective of why you're in a regulation scheme. And obviously they're there to protect the public. They are not there to protect, in our circumstance, osteopathy. They are there to protect the public. And it's actually within the regulation and legislation that drives how they operate that the primacy of the public overrides the primacy of a health practitioner. So, their job is to protect the public. And if that means diminishing the rights or right to practice of practitioners, then they have the power to do that. So it's really important that, they are there. Yes, there are some benefits, and I'll go through some quick pros and cons because they do enforce a minimum standard. You do get recognition. The scheme was not set up there as sort of a recognition, but unfortunately lots of governments have used it in that regard, which has been challenging for the professions that are less likely to harm people and therefore are self-regulated, in the fact that they might use it as an easy way of saying, oh, we'll put these professions in a funding scheme because they're AHPRA registered. But they don't do that unilaterally. So, we do have this, each state has their own state funding schemes and sets the rules for it. And so for workers' comp or traffic accident, nearly every state recognises osteopathy and funds within those schemes. But when you look at who they recognise as allied health on their websites, only 3 of the states recognise osteopathy as allied health, even though they fund them in a state scheme. And federally, although osteopaths are funded in Department of Veterans Affairs, Medicare, NDIS, and a range of other services, not at the same level as a pool of other professions, and then they're excluded from a whole range of other federal funding schemes. So it's not like being AHPRA registered suddenly grants you access to a whole range of things. Likewise, it does make getting a provider number slightly easier because they use registration, but that doesn't mean every fund's going to still allow you to be within their funding schemes or set the rebates equally with other professions. So it really is there around setting minimum standards for health practitioners and protecting the public, not promoting your profession. But some of the real pros are that setting standards, that recognition shouldn't be. They get rid of bad eggs. So, if people do bad things, which really damages the reputation for the whole profession, there's someone who actually has the power to either fine or prosecute or potentially send off elsewhere to be jailed for their behaviour. And it does streamline some of the bureaucracy, i.e. it's easier to get a Medicare provider number and it's slightly easier to get a private health insurance provider number because they've linked them all attached to having a AHPA registration number. But then, of course, it also, as one of the cons, it's added a whole pile of other obligations that you have to do. So obviously you have to pay for your registration. It's a user pay scheme, so the more complaints there are, the higher your fees go. So it's in everyone's interest to reduce complaints and behave badly because, so for instance, we're aware, and this applies to all, going to a tribunal because someone's a state tribunal, because that is likely to cost somewhere between $50,000 and $100,000 in legal costs and other bits and pieces. And so that's a cost that is applied to AHPRA as being the people prosecuting. And so therefore that cost is shared across all the osteopaths. So the more complaints there are, the higher the fees get, sort of thing. So, but also it comes with a whole pile of annual obligations that are not negotiable. The hours of CPD you do, what your insurance must cover. And so therefore, because it's set at a higher level, they're generally higher cost than cheapest insurance. So because they have to meet certain standards, you have to work so many hours a year, or you may not be considered recent in practice and therefore can't practice. If you haven't had recent practice for a while, you may have to apply to return to practice and have to go under supervision for a period of time before you can get back into practice, sort of thing, which is great because, again, it's protecting the public, but it's a whole pile of obligations people don't do. And in business, it has a really big impact in the fact that for most myotherapists and massage therapists, you're advertising, you're still going to comply with state laws, but you can use testimonials, you can make a range of claims as long as you're not being outrageous. Under the AHPRA scheme, if you are claiming treatment has a benefit, you must be able to cite blinded clinical trial data that demonstrates that benefit. Otherwise, you are falsely advertising, and you cannot use testimonials that talk about anything clinical. So you can say their reception is great, but if you said, I always feel better when I leave seeing blah, you have to remove it, or you're in breach of the advertising standards, and you can be fined up to $10,000 a day.
Wow.
So there's a lot of things. It's just really important to remember they are there to protect the public and set minimum standards. It's the association's role to promote the public and enhance standards or push scope, because AHPRA does not regulate scope, but they will prosecute you if they don't think you've practiced out of it.
It's interesting. I mean, thank you for that, because I have learned a lot just out of what you've just said. And a lot of it is what us as an association of a self-regulating industry mirror, like our code of ethics. We don't recommend using testimonials because, it can devalue your work, in the health sector, which is what we're talking about. We have a robust ethics process, but at best, all we can do is remove them from our association. So then it needs to go further into, the healthcare complaints commissioners. So, but whereas AHPRA have that power, so to speak, to manage all of that, which is a good thing, is a bad thing. It's very difficult to know, isn't it?
It's a balance. There are definitely pros and cons.
Yes.
But as an example, just a couple of weeks ago, they sent out a press release around a registered professional who was suspended from practicing. So they were not allowed, they continued practicing. So under the regulation, there's a thing called holding out. You're pretending to be something that you're not. And they can prosecute you for that. So they were in legal and fines that individual, because they kept doing that for 6 months, has had to pay $40,000 and has now had a criminal charge added, which means they may never get registered again.
Which is a good thing, because it's
Yeah.
not good for the industry. It doesn't matter what industry it is, for the allied health industry or those AHPRA registered modalities, it's not a good look for anybody across the board.
I think what's interesting about this conversation is that intersection between a definition of allied health and regulatory model. So being AHPRA regulated does not necessarily infer you benefits that we would like to think it does. So a good example are Chinese medicine practitioners. They are AHPRA regulated, but they don't have an MBS item. And I think we've got, through the NDIS, through aged care reform, we've got some examples coming up where just because you are an AHPRA regulated profession does not mean that you're eligible under a particular funding mechanism. So I think we have to disentangle what AHPRA regulation affords, and Antony's really well unpacked those, but it doesn't solve problems that are actually funding problems. And so I think we just need to look at examples would be title protections. So title protections are of benefit to the profession, but it doesn't necessarily infer the level of benefit that we would want it to for a self-regulating profession. So I think it's warrants unpacking that a bit more deeply. If you're a self-regulating profession, entering into the AHPRA scheme isn't necessarily the pot of gold that it might look like on the surface.
No, and I quite often have conversations with our members, and that is my response to them. Almost be careful what you wish for. And after what you've just unpacked, Antony, it does not mean that you instantly are going to get all these what they believe as benefits of being a practitioner. And you may even be told what you can charge. Am I correct? They set consultation fees.
They won't set the consultation fees, but there is a range of rules around, they must be transparent. They must be available beforehand. Someone complains and wants their money back. Quite often, if you haven't got great notes, well, your insurer will probably recommend getting the money back. But the regulator may also say, no, we think you've practiced badly, and give them their money back. And we're now going to put conditions on you. So they don't set the actual cost. Some of the funding schemes may, in the fact that some, the Department of Veterans Affairs and some workers' comp schemes do not allow charging a gap. So the rebate is the fee. You can't charge above it, sort of thing. And I think that the other challenge is the regulator, AHPRA, has a whole pile of rules. But as your members know, so does every health fund. So does DVA, so does Medicare. So it's not as like it's like, oh, this is easy, we just have to follow these rules. Every funding scheme has their own rules. Every, health insurer does this, that. So you've still just got more rules to work out. It's not as if suddenly there becomes the one set of consistent rules, sadly.
And I think that's a good point, in that what we want our practitioners and our members to see is that it's not about being registered, it's about being recognised as a valid service, a valid modality, a valid healthcare service, not just to think that you're going to have this magic ticket through AHPRA registration. So, and that's the job of the association, to ensure, talking to people such as yourselves, being affiliate members of AHPA and being in there in the conversations, so that people are aware of massage, remedial massage and myotherapy, and this whole world of multidisciplinary care and aged care and aging population and all those sorts of things that, that we work on as associations that people don't realise.
It's a really good point, Anne, because we don't have policymakers making decisions about eligibility into funding mechanisms based on regulatory status. So we're not saying, okay, so all of you AHPRA regulated allied health professions, you're in, because you're AHPRA regulated. That's not the decision. So I think we have this tendency to mix, to convolute or to fold these two things in together when they're actually quite different. So eligibility for funding mechanisms is not based on your regulatory status. And so we need to separate those out and not have, they're two very different conversations.
Absolutely, they are. And I think sometimes and I think one of you alluded to it, government or policymakers or any fundings, they go back to what's easy. If you're AHPRA registered, you're in, just because it's an easier path to go down. And then they look at it and go, oh, well, maybe we were wrong. And, we've found that with many instances. Yeah.
I think also people assume, or practitioners assume, that politicians and policymakers actually know or understand well who's in the scheme, the AHPRA scheme, and who's not. Because quite often when you point out that professionals like social work or speech pathology, dietitians are not in the scheme, you can see the little cogs going in their head that they hadn't quite worked that out. They just assumed they were in there. And they just really, I think COVID highlighted it very clearly, state and federally, is that lots of governments across Australia, for our glorious federation, have no idea about allied health.
Yes. And that's what you're there for, I suppose, Bronwyn, is to inform, and our Chief Allied Health Officer. But we have so many layers of bureaucracy in our government system that it's baby steps all the way, isn't it? And 2 baby steps forward and 1 baby step back. And that's for registered professions as well as self-regulated professions, isn't it?
Look, so last year, our new Federal Chief Allied Health Officer, Anita Hobson-Powell, signalled to the sector that a piece of work for her office this year was to create a list of allied health. So essentially, in scope allied health professions and out of scope allied health professions. And some of those criteria or principles that I read out earlier, some of those might go towards our understanding of who's on and off that list. But the intention of that list, or the hope of that list, is that it's then adopted by policymakers. So when they're sitting there looking at, okay, so we're putting together a new model of care, which professions are going to be included in that model of care, rather than making it up. And to Antony's point, we're the only ones walking around living and breathing allied health and who's self-regulated and who's AHPRA regulated. But that's not the determining factor of how you've made it onto the list. So provided you've got an enforceable regulatory mechanism, that's enough. It doesn't say self-regulated or AHPRA regulated. It's just you need to have a formalised regulatory model in place, because that's what affords consumer protection. So the intention of that list is that it should be used, and we will work with the CAHO this year as that unfolds.
And it's a good point, because a lot, and I know health funds use this term, they say our unregulated modalities, and we say no, we're not unregulated, we are self-regulated. It may feel like semantics, but it's 2 very different things.
Oh, it's super important, even the term registered. So we're actually AHPRA regulated, we're self-regulated, and then we are truly unregulated. So unregulated professions are PCAs or disability support workers. So, and that's a whole other area that also needs to be addressed through the NRAS complexity review. But we have to be really careful that we don't confuse our language. So self-regulating professions end up being in the same bucket as unregulated professions.
Yes.
So, it's not, you're right, it sounds like it's semantics, but I think it's really important. And I think that Antony and I probably spend a fair chunk of our time when we're talking to policymakers slightly correcting their language when they talk about self-regulated as unregistered. And we're saying, no, it's not unregistered or unregulated. They're self-regulated. And there is a difference.
There's very much a difference. So I suppose that leads me to my next question. And I know, Antony, you're excited about this one. What would, if you could develop a utopia, what would an ideal world be for your members?
Well, probably my first one's a bit controversial in the fact that I'd say we would have to abolish federation because we're never going to get there while we have effectively in Australia several dozen health systems because we've got state and federal, we've got public, private, we've got health funds and then schemes and this. So, you know, it's incredibly complex. No one individual really can understand it. But I suppose at a much higher level, I think one of the biggest challenges for us is in a utopia that both governments and departments and health policy people within them would base their decisions based on logic and outcome for consumers, not political power or loud voices. And we see it in healthcare again and again and again. Decisions are made because we don't want to upset certain players over this is a demonstrated outcome for consumers, and therefore we should fund this to get a good outcome for consumers. But we won't because it might upset those people over there who have a big loud voice and a lot of political voice. I think that, and attached to that is the fact that what that has done and what I would like to change is that all health professions who have been trained to do certain skills could practice at the top of their scope or use those skills to benefit consumers. And what we see is there are a whole range of health practitioners who have overlapping and similar skills, and some of them are funded to use it and others are not. So the system has to get to a way where it's like, well, this sort of treatment, these are all the people who can do that and are funded equitably to do that so that you're enhancing the workforce, you're enhancing access for consumers to get to those people and, you know, and therefore better outcome for the consumers sort of thing. So, and I think, you know, we still see it, you know, a lot. I would say a lot of the current schemes, the professions who are in them are the ones that have just been around there for a long time. For new professions, we have a huge array of hurdles put in front of us. Data they need, you need to demonstrate X, Y, and Z. That was never done for those other professions. Never. But you want in? Now we want to do it with you. Well, it's just like, and I'm as osteopathy, because we get it a lot, and I would be happy to do that if you'd actually done it to assess everybody else or did it regularly to reassess everybody to work out whether actually that is, because scopes change over the years sort of thing. So it's this false barrier around, we're going to make it really hard for you, but we've decided suck it and see over here because that's historically who worked in that space. So why wouldn't we roll them out in a whole pile of areas? I think. So I think that, again, that's that equity, and that equity impacts health professions, but it ultimately impacts consumers because they have made a choice. This is the practitioner I'm really comfortable with. I know they have those skills. Oh, but I want that service. I have to go over there to someone who I don't have a clinical history with because that's where the funding is, even though this person has the same skill. And I think the final one, which is really overarching and is allied health are the second largest profession in Australia, health profession in Australia, at least a couple of 100,000 of them spread around the country. And unfortunately, like I said earlier, governments have not realised that there is this huge untapped health workforce while they're whinging and complaining about access and equity and we need more health workforce, etc., etc. Whereas they've got one, they just refuse to create modern health systems to optimize it to benefit consumers.
Oh, very succinct, I think. I cannot add to that. It just resonates so much with what we deal with as a self-regulated profession and that overlap. And, massage is in for example, Department of Veterans Affairs schemes, but it can't be delivered by a massage therapist. It has to be delivered by an AHPRA registered practitioner. Yeah. So again, there's that easy path of this is where we create the boundaries. So, Bronwyn, what about for you?
I agree with all of those. And where I'm going to start is probably where we've just ended. So I've got 5 elements to my allied health utopia, but the first one is similar, and that's about culture. So culture absolutely drives, in my view anyway, culture drives policy rather than evidence and cost effectiveness. So in my utopia, evidence and cost effectiveness drive policy decisions rather than historical decisions based on really what is a hierarchy of medicine, nursing and allied health. And we very much sit at the bottom. Our Chief Allied Health Officer is part-time, whereas we would never consider having a part-time chief nurse or a part-time chief medical officer. So those decisions for me sit at the very top of everything hangs off culture, both state and territory and federal. My second part of my utopia is about funding. So funding models that are actually designed to support access to multidisciplinary healthcare, not funding models that are built on episodic models. So we obviously have some allied health professions have an MBS item that allows consumers to access 5 subsidised sessions a year. And that is woefully insufficient for your average person that has a chronic and complex condition. So in my utopia, we actually build out funding models that fund for multidisciplinary care. At the moment, I feel like we talk about it a lot and we all think it's a really good idea, but we don't fund for it. So therefore, you can't have it. My third is about workforce. So to Antony's point, it's the second largest health workforce in the country, but we still don't have a national allied health workforce strategy that secures the pipeline into the allied health professions or retains who we've got. So a piece of work for the CAHO at the moment is developing, and it's out for consultation now. So if any of your members feel so inclined, the National Allied Health Workforce Strategy is open for consultation now. It's the final draft. So this is your final opportunity to make some comments about the scope of that 10-year strategy. And it's fundamental to securing the long-term security of the allied health professions, which includes yours. If I was your members, I would be commenting on that strategy. Absolutely. My fourth part is about digital integration. So there's been a lot of investment over the last decade, maybe 15 years, into integrating clinical data into things like the My Health record to the exclusion of allied health. So there is a piece of work underway now between the Digital Health Agency and AHPA is a part of that brings allied health into the digital ecosystem, which includes digital products, but we're about 10 years behind. So if we want multidisciplinary team care in our allied health utopia and we're going to fund for it, then we need to build digital systems that enable allied health to put in the clinical data that they generate and be able to see the clinical data that other health professionals generate, like general practitioners, for example. And my final piece, although I have thought of number 6, but my final piece, which is number 5, was to fund research. So if we look at the allocation of MRFF research, very little goes to primary care and an even smaller amount of that goes to allied health, which links us back to number 1. So if we want to demonstrate value, either value to the consumer with their improved health outcome, or we want to demonstrate cost efficiency, that costs money to demonstrate. And historically, we have really, apart from those very large allied health professions, those mid-tier down don't have a lot of that gold star standard research because it's expensive. And there's really good examples of associations forking out a lot of money to fund clinical research because there's no other way to get it. But actually, that's not acceptable, because when we look at our medical and nursing colleagues, they do not pay to do their own research. It's funded through the MRFF. So that would be 5. But my number 6 that I just thought of is really about proms and prems. Is we do need to be able to systematically measure what we do, because we know that allied health adds considerable value to the consumer within that multidisciplinary context, but we're not particularly good at systematically measuring it and then using that data to inform future policy arguments. So I would love for that to be funded, and for all allied health providers to be funded for proms and prems integrated into their digital ecosystem. That's mine. I feel like there's lots more, Anne, but that's probably enough for now.
I can see Antony wriggling in his chair, and I'm thinking, does he want to add to what Bronwyn's just said, or you were just agreeing? And look,
Just agree. Just agreeing.
And it does come, you can bring that back to basics as well, because we get some members who say, you just want us to do continuing education so that you can make money from us. No, every industry, I have to do continuing professional education with the associations that I'm a member of. Client notes. It's not that we're just saying you have to do it this way. Legally, you have to take notes, but also they're to protect you as well as your client, your patient, your consumer. Because if ever there was anything to go wrong, if your notes are there, they're there. And that all comes into that digital strategy of knowing who's treated what, who's doing what, connecting that whole multidisciplinary care. And I do agree with you, Bronwyn, we are a long way behind. But AHPA are working hard to get us back up there. So
I think you can't have it both ways, as in, you want to be, not you per se, but as in, if we look at health professions, if you want to operate as a health profession, there's minimum requirements that underpin that. And they come back to quality and safety. And the way that we maintain, obviously, quality and safety is that you can't just complete your degree or your diploma and then go out into the world and you do that for 30 years. And there's you can, but you can't do that and then expect to have funding mechanisms underpinning your business model, because there has to be a check and a balance somewhere in there. And that's where we bring the regulatory model in. Like, it's nothing more or less than that. It's just a mechanism that allows us to maintain a minimum quality and safety standard. And so when I look at self-regulating professions, the arrangement that NASRAP, so the National Alliance of Self-Regulating Health Professions, sets the standard or the minimum requirements for self-regulating professions to meet, those standards are mimicked off AHPRA. They just don't have the legislative backing that underpins them. That's the problem with them. But it allows us to put a check and a balance in place to say, if we are going to put a prom and a prem piece of funding on top, or if we are going to bring you into the My Health Record or another digital product, there has to be a minimum requirement in place before we allow people to access people's health data and to be able to contribute to the health record in some form.
Totally. And I describe all these things, it's like a spider web that is not connected, and everybody's working towards the same goal, but there's so many barriers, there's so many challenges, but there's so many successes and positives. And I, as CEO of Massage and Myotherapy Australia, I am so grateful to Bronwyn and you, Antony, and the team, because we've learned so much. We're part of the digital health agency work that you're doing. And if you weren't there, we wouldn't know about it if we weren't affiliate members. So again, it's that whole spider web of we're all trying to achieve the same thing and have safe public, safe consumers, quality practitioners, and a brand in every industry that is reputable and respected and not challenged by bad eggs, as you called them earlier, Antony. So, look, it's interesting to hear, and I think for our viewers, because we are self-regulated, that the registered or regulated professions have just as many challenges as what we have, and possibly more, or the same challenges, as you alluded to before. So anyway, I must thank you. Is there anything you want to add or final words of wisdom for our members other than be professional and look after your practice and look after yourselves and your patients? And
it's a good question. My final observations to members would be a member of your professional association, whatever your professional background is, and don't do it on your own. So I think it's hard for policymakers to make decisions if they're not getting unified policy advice. And so in all professions, for our clinicians that are on the ground, you're often the ones that come across issues first and foremost before we do. So feed them through your professional channel, and often they make their way up to AHPA if they're system-wide issues. But I think it's really important that we operate as a collective. So individual voices don't tend to be terribly successful on their own, but what we know is more successful is if we operate together. And so AHPA's core business is policy and advocacy, and our members are not individual clinicians. They are the professional associations. And not all associations are going to agree on everything, but you don't need to agree on everything before you start working together. And so my biggest advice would be to be collaborative and be cooperative, and you're much more likely to be successful on behalf of the whole profession if you can put aside your professional differences in front of policymakers and have those discussions where you do differ, have them privately. Don't play them out over LinkedIn or over Facebook where everybody can read them. Have them privately, and then your external public front is unified. And I think we're more likely collectively to be successful if we operate like that.
I think that's brilliant. That's good advice. I think, and as you're aware, there's several massage associations, but we do work together. And I think, again, to mention COVID, it brought us together, and we continue to work together, which is fantastic. We've just finished one project. We're moving on to another one.
And it's smart to work together. Yeah,
it is. It is, exactly. So
government loves if different representatives within a profession want to argue with each other, because all they do is they can't agree, just don't include them. It's a simple out for them. I agree with everything Bronwyn's just said. I think, but coming from one of the regulated professions, and I know a lot of your members and our members work together in clinics with each other or refer quite a lot. And so I think, lots of people look to osteo and go, oh, well, it's so much easier for them. But, AHPRA isn't a golden bullet. Being in Medicare isn't a golden bullet. I can guarantee if we looked at Massage and Myotherapy Australia's strategy and advocacy plan and ours, there would be minor differences, but a lot of the same stuff is, why are we in this category in aged care, not that category? Why can't we do this? Why can't we do that? Why is physio included in that, but we're not, etc. It's just the reality of the world. This is probably slightly more contentious, and as an association and our members work with your members and of the many others. But from my perspective, one of the reasons osteopathy advanced is for nearly 40 years, there has only been one national association. They all merged so that basically there were not competing voices. There was one voice, and that has had probably a huge advantage, probably the biggest single advantage for the profession, in the fact that it could concentrate those resources to represent and be the voice of the profession. And I'm not saying it's not challenging, and we understand the reason why but I think it will always slightly drag the profession down while there are multiple associations. And probably the other thing which we say still to our members, but I think it applies equally to yours, and that's basically every bad massage therapist or myotherapist and the PR that goes with that damages every single one of you. And so when you know people are doing the right thing, partly the role of your association and you as a health professional is to stop them. And that means that uncomfortable things of potentially being the person who lodges the complaint, or if one of their customers has come to you and explained what they're doing and you knowing that's not appropriate, encouraging them to complain and understand the rules, because a person doing whatever is damaging. If that person goes off and never sees another massage therapist or a myotherapist, that's their perception of your entire profession and how they explain it to everyone else they know. So,
well, and totally agree with that. What one person does affects the entire profession. So we want everybody to be that good egg and make the profession look as professional as what we want and be part of the health sector. So, well, thank you so much. I really appreciate your time and for clarifying what AHPA does, what AHPRA is, what, the challenges that the osteos have been AHPRA registered, and it's clarified it for me. So I really appreciate it. Thank you so much.
It's our absolute pleasure. I feel like we could have talked for a lot longer now that we've
Absolutely.
started. Thank you for having us along.
Yes, we could.
Thanks, Anne.
thank you.